This is Blood and Cancer News. I'm your host, Nick Andrews. This week in Blood and Cancer News, the FDA approves combination immunotherapy for first-line mesothelioma. Apatinib plus gefitinib leads to better progression-free survival, but more toxicity. And later, atezolizumab strikes out in ovarian cancer. But our top story today, radiotherapy planning scans may be a rich, untapped source of information for estimating the risk of cardiovascular disease in patients with breast cancer. This is according to the results of a study presented at the 12 European Breast Cancer Conference, also known as the EBCC 12. In the study, researchers retrospectively studied nearly 16,000 breast cancer patients who had radiotherapy planning CT scans between 2004 and 2016 at 3 different Dutch institutions. The researchers used an automated deep learning algorithm to detect and quantify coronary calcium in planning CT scans and to calculate the coronary artery calcification score, or the CAC score. Those categories were a score of 0, a score of 1 to 10, a score of 11 to 100, a score of 101 to 400, and a score of more than 400. The median follow-up was 51 months, or over 4 years. Most of the women did not have any calcium in their coronary arteries, while 3% of women fell into the highest category, which was over 400. The researchers reported the following incidence rates of non-fatal cardiovascular disease based on CAC scores: 5.1% with a score of 0, 8.5% with a score of 1 to 10, 13.5% for a score of 11 to 100, 17.6% for a score of 101 to 400, and 28% incidence rate with a score of greater than 400. In analyses adjusted for age, laterality of radiation, and the receipt of cardiotoxic agents like anthracyclines, the researchers reported that women with a score that exceeded 400 had sharply elevated adjusted risk of cardiovascular disease events and risk of death from any cause compared to women who had a CAC score of 0. When the researchers looked deeper into CVD events, the researchers found a similar pattern regardless of whether radiation was left or right-sided. However, the association was stronger among women who received anthracyclines compared to their counterparts who did not. In a survey, the researchers reported that nearly 90% of women said that they wanted to be informed about their CAC score and associated cardiovascular disease risk, even in the absence of evidence-based reduction strategies. So how can these data be applied? Dr. Helena Verkooyen is with the University Medical Center Utrecht in the Netherlands. She presented the findings at EBCC 12, which of course was held virtually. She said that this information that we haven't really requested. She also said that she thinks clinicians should only use this kind of information when there's a clear strategy on how to help patients reduce their risk of cardiovascular disease. And for the first time in 16 years, a regulatory agency has approved a drug regimen for mesothelioma. The FDA approved combination nivolumab and ipilimumab to be used as the first-line treatment of adult patients with unresectable malignant pleural mesothelioma. Back in 2004, the FDA approved pemetrexed in combination with cisplatin for this indication, and now patients have an important additional treatment option for more than a decade with only one FDA-approved drug regimen. That's according to an FDA statement. The approval comes based on efficacy results from the CheckMate 743 trial. That trial compared immunotherapy with a chemo regimen in a cohort of more than 600 treatment-naive patients with unresectable mesothelioma. In CheckMate 743, patients were randomly assigned at a 1-to-1 ratio to receive either nivolumab and ipilimumab for up to 2 years, or to receive 6 cycles of combination chemotherapy with cisplatin or carboplatin. The results were initially presented earlier this year at the World Congress on Lung Cancer 2020. The combined immunotherapy regimen was associated with a 26% improvement in overall survival. At 2 years, 41% of patients in the immunotherapy arm were still alive versus 27% in the chemotherapy group. Overall, the trial demonstrated a statistically significant improvement in overall survival for patients who received nivolumab plus ipilimumab versus those who were treated with chemotherapy. The median overall survival was 18.1 months versus 14.1 months. Median progression-free survival per blinded independent central review was 6.8 months in the nivolumab ipilimumab arm and 7.2 months in the chemotherapy arm. The confirmed overall response rate was 40% versus 43% in the immuno and chemo arms, respectively. The recommended doses for unresectable malignant pleural mesothelioma at nivolumab was 360 milligrams every 3 weeks, and ipilimumab was 1 milligram per kilogram every 6 weeks until disease progression or unacceptable toxicity, or up to 2 years in patients without disease progression. The most common adverse reactions in patients receiving combination immunotherapy were fatigue, musculoskeletal pain, rash, diarrhea, dyspnea, nausea, decreased appetite, cough, and pruritus. Dr. Paul Boz is with the Netherlands Cancer Institute in Amsterdam. He was an author on the study. In his presentation, Dr. Boz suggested that combination nivolumab and ipilimumab should be considered as a new standard of care. And adding apatinib to gefitinib as first-line treatment for patients with EGFR mutant non-small cell lung cancer improved progression-free survival. This comes from the results of the ACTIVE trial, which were reported at the 2020 European Society of Medical Oncology Congress. The ACTIVE trial is the first phase 3 trial of an oral vascular epidermal growth factor receptor 2 tyrosine kinase inhibitor added to an EGFR TKI as first-line therapy for these patients. The researchers evaluated 313 patients with locally advanced metastatic or recurrent non-squamous non-small cell lung cancer. All patients in the trial received gefitinib at 250 milligrams per day. Patients were randomly assigned to receive either apatinib plus their gefitinib at 500 milligrams per day or to receive placebo until progressive disease or unacceptable toxicity. The median follow-up was 15.8 months, and the primary endpoint was progression-free survival by independent review. The researchers reported that the median progression-free survival was 13.7 months in the apatinib group and 10.2 months in the placebo group. Objective response rates were similar for both groups at 77.1% in the apatinib group and 73.7% with placebo. However, depth of response at greater than or equal to 30% and greater than or equal to 50% both favored the apatinib arm with statistically significant p-values. You can find a link to the full data in the show notes. In addition to depth of response, the researchers also found that the median duration of response was longer for the apatinib group at 12.9 months compared to 9.3 months in the placebo group. So how safe was the combination? The rate of grade 3 or higher treatment emergent adverse events was 84% in the apatinib arm and 37% in the placebo arm. 73.2% of patients experienced diarrhea, 68% of patients experienced hypertension, which were the most common treatment emergent adverse events in the apatinib group. Dose interruptions were more common in the study group at 59.5% compared with 22%, as were dose reductions at 48% versus 4%. However, treatment discontinuations attributable to treatment emergent adverse events were few in both arms at 5% versus 2% in the placebo arm. Despite these findings, there may be reason for hesitation. Dr. Alicia Sequist is with Mass Gen in Boston. She pointed out that VEGFR TKIs like apatinib have not yet found a home in lung cancer. During the discussant portion of the presentation, Dr. Sequist listed 10 such drugs and pointed out that none of them have changed practice. She added that while an all-oral regimen is appealing, the benefit of adding apatinib to gefitinib was modest and the regimen was fairly difficult to tolerate. Dr. Sequist also observed that most studies have shown a PFS benefit, but no overall survival benefit. She noted that in combination with the toxicity, this makes her a little hesitant about this regimen. And finally today, atezolizumab failed to improve progression-free survival when added to first-line bevacizumab plus chemotherapy for patients with stage 3 or 4 epithelial ovarian primary peritoneal or fallopian tube cancer. This is according to the results of a phase 3 trial of patients that was also presented at ESMO 2020. In this study, researchers randomly assigned 651 patients to receive atezolizumab with their bevacizumab and chemo, and 650 patients to receive placebo with their bevacizumab and chemotherapy regimens. 73% of patients had ovarian cancer in the placebo arm, and 75% had ovarian cancer in the treatment arm, while the rest of the patients had fallopian tube cancer at 16% in the placebo arm and 17% in the treatment arm. 10% of patients in each group had primary peritoneal cancer. So let's look at the results. In the intention to treat population, the median progression-free survival was 19.5 months with atezolizumab and 18.5 months in the placebo arm. In PD-L1 positive patients, the median progression-free survival was just under 21 months and about 18.5 months respectively for the treatment arm and the placebo arm. The researchers reported that the differences in progression-free survival in the groups were not statistically significant or clinically meaningful. Dr. Kathleen Moore is a researcher at the University of Oklahoma in Oklahoma City. She pointed out that results were not stratified by BRCA status, which has been linked to PFS in ovarian cancer, and a potential imbalance between the groups might have contributed to the negative results. In the intention to treat population, the median overall survival was not reached in either treatment arm. In the PD-L1 positive population, the median overall survival was 31.2 months in the placebo arm and was not reached in the atezolizumab arm. Adverse events were consistent with the known safety profiles of atezolizumab and the other drugs in the regimen. There were more serious events and more events leading to discontinuation with atezolizumab. Adverse events more common with atezolizumab included febrile neutropenia, pyrexia, thyroid abnormalities, and rash, including severe cutaneous reactions. Colitis, pancreatitis, and infusion-related reactions were relatively infrequent, but were more common with atezolizumab. And that's it for this edition of Blood and Cancer News. I'm your host, Nick Andrews. Blood and Cancer is produced by MD Edge editor Jennifer Smith. All of our podcasts are produced by executive editor Kathy Skarbeck.